Hello students, so this is Dr. Anoop, your psychiatry faculty, and I am here with the recall questions of our NEET 2021. So you all had a wonderful exam experience, I hope, and got things well, got things right. So regarding psychiatry, so I was really surprised actually when I got the questions from students. I was in fact doubtful when I got just 4 questions, 4 or 5 questions, hardly 4 questions or something, and lot of areas were missing. Like I expected questions in pharmacology, certain areas, but it was not there. It was a bit surprising, and number of questions in fact went a bit down. I expected a bit more, but anyway, the questions were fine, simple, basic questions, not troubling the students much, and I'm happy that things were what I have discussed in the class, and students were able to do it well. So I thought of just having a recall, just having a basic idea of what all you should know. See, one of the basic reason for discussing these questions are entrance examination is a continuous process. So one exam comes, it goes, then comes next exam, and so you should have a basic idea of what are the areas asked. And I often used to tell that this preparing for entrance examinations like a chess game. See, I like chess a lot. I often discuss that in the class. So it is like recognizing the pattern. So difference between an amateur and a grandmaster is a difference in recognizing the pattern. A grandmaster can quickly analyze a position and see that this has been long time you have seen this pattern and able to identify. Likewise, you should be able to identify the important core areas and what all can be asked from these areas. So let us discuss. I have already told that you should have an idea about various stems of the questions. What are the questions that can be asked, and what are the stem or topics. So going on to first question. Which of the following is included in form of thought disorder? So form of thought disorder. When I take the class, I often used to spend some time teaching psychopathology. So this is one of the important area. The psychopathology is one of the important areas where a lot of questions are being asked, lot of terminologies. So I used to tell students that the first part of my class will be really boring because I'm going to deal you with mental status examination and psychopathology, various terminologies. May appear a bit dry, but these are very important because a lot of questions are being asked. So first, let us have just a basic idea. The mental status examination, there is something I often discuss in the class. The mnemonic is GPSATP. G for general appearance and behavior. P for psychomotor activity. S is for speech. A is for the affect. T is for the thought, and P is for perception. The thought is again divided into form, stream, possession, and content. So there may be people who have not access to my class but are watching me for first time sometimes. So that's why I'm just going and brief on this. These are detailed in my notes, but I'm just briefing on this. So GPS ATP of this thought is again divided into form, stream, possession, and content. Now, what is mean by this form, stream, possession, and content? So for some people it may appear like a Greek and Latin. So I'll just tell you a story. Think of this already discussed in my class. So students who have accessed my notes know it, but for newcomers like I am discussing. So this is the mighty Himalayas, the mountain Himalayas. From this comes a famous river in India called as Ganga or Ganges. Okay. So You can remember river Ganga originate from Himalayas or is possessed by Himalayas. So, how will be the river flowing? River will be flowing at a various speeds. Some places will be very slow, some places will be very turbulent. So, river Ganga flows or a stream at varying speed. River Ganga contains water. So, Ganga contains water, and water is liquid form of H2O molecules connected. So, river Ganga originates from the Himalayas. The river Ganga flows at varying speed. The river Ganga contains water, and this water is in liquid form with H2O molecules connected to it. So, replace now your river Ganga with thought and Himalayas like as mind. So, the thought you originate from mind. The thought flows or a stream, there is a stream, the stream of thought varies. Sometimes it is thoughts come fast, sometimes thoughts come very slow. What is the content of this thought? The content of the thought, that is called as explained under content. And the form of thought is a logical connection between the thoughts. Like the water molecules are connected, the shape of the thought means a logical connection of the thoughts. So, based on this, the thoughts are described under these headings, and when a problem is there, there are disorders of the thought also under varying headings. So, one is, so form of the thought is like the water molecules, the logical connection between the thoughts. So, there are, when this logical connection is lost, it causes disorders of form of thought. So, disorders of form of thought means there is loss of logical connection of thoughts. What is derailment? You know the railway track, the train is going a track. What happens? It loses off the track. Likewise, when the logical connection of the thought is gone, the loss of connection, it is called as derailment. I am just putting into simple terms only, just for discussion purpose. I am not going into the details as I discuss in the notes, but basic. So, there is a loss of logical connections. There is another term called as tangentiality. All are like synonymous with some sort of a derailment. That is, here what happens, this is a topic. So, the thought has an origin and a goal. The thought originate. For example, if you ask me how should I study psychiatry, I start with this and I reach a goal. So, when it goes tangential or oblique, that is called as tangentiality. For example, so I hope you got what is meant by derailment. That is the loss of logical connection of the thoughts. Without having a connection, it goes from one place to another. So tangentiality, as I told, like an often asked question I used to discuss in the class is like, it's a question I used to put for MCQ exams and for students also. Like for a question, how much time do you sleep? The patient answered, I sleep in bed, but sometimes I sleep in sofa, but sleep is essential. He started with the topic, but he is going tangential or oblique, deviating from this. So, this is called as tangentiality. So, he goes about with the sleep, but he goes deviates from the topic. The initial part appears to be more like going together, but it deviates from the top. So it is also synonymous with some sort of a derailment. So for assessing a derailment, what you do is like you give a patient a neutral topic. How do you play cricket? How do you celebrate Diwali? And how he is able to answer is what you look for. So you should start with the thought. It gives a logical connection from one idea to another, and it comes like this. If you ask me, how should I study psychiatry? If I say that psychiatry is an important part of entrance examination, there are a lot of entrance examination in India. NEET is one such examination, and NEET may sometimes change to next. You should study well for NEET. Lot of questions in medicines come from NEET, etc. If I deviate, it is like I'm having the derailment. I'm just deviating from the topic. So this is what is called as derailment. So, and there are several terminologies like loosening of association, loss of the connection between the thoughts. You learned in schizophrenia and all, we heard this psychosis and all, loosening of association. When it is very severe, loosening is very severe. If the loosening gets very severe, the worst thing that can happen is that the speech becomes simply an incomprehensible mixture of words, like what you give in salad. Several vegetables are put together without an order. So that is called as word salad. So the basic theme of this is derailment, that is deviating from the thought and loss of the logical connection, so that you deviate from the goal. From the beginning to the goal, you get deviated from that. That is called derailment. And various synonymous terms like tangentiality, these are all almost related to derailment with some subtle difference. The loosening of association, when it is severe, it is called as word salad, etc. So that is a disorder of form of thought. So the answer here is derailment. So likewise, there are something called as disorders in the stream of thought. So stream, we thought that it is called as a speed. So there are conditions that can be disorders of stream of thought, that is speed of thought. There is something called as possession of thought. I am just discussing the details what is given in the question. So I am not going into much details. So possession of thought means, like we told that who possesses thought, like river Ganga is possessed by or originate from Himalayas. So likewise, thought originate from mind. Okay, but whose mind? So thought comes from mind, but the question comes is whose mind? Yours or others? That is, there are some conditions in which the subject understands that the thought is coming from his own mind. One such example is obsession. So obsession is also a disorder of possession of thought. There are certain conditions where the subject feels that his thoughts are manipulated by an external agency. An external agency is manipulating his thoughts. So that is known as thought alienation. So obsessions are disorders of possession of thought. Thought alienations are disorders of possession of thought. So in thought alienation is seen in psychosis like schizophrenia, where it can be thought insertion, like somebody else is putting a thought into, these are not my thoughts, somebody else is putting a thought into my mind. It can be thought withdrawal, somebody else is taking away my thoughts, and thought broadcasting, like my thoughts are made known to all the people. So thought alienation and obsession, so disorder of, both of them are disorders of possession of thought. So that is what you should understand about possession of thought. So I hope you understand like form and possession. Stream, anyway, since examples are not given, I am not going to detail. Then, so I started discussing with the patient, what are there in his thoughts. So the patient was telling that his wife is having affair with an extra terrestrial creature, or maybe with the neighbor or with the American president, and they are meeting in secret. There's rendezvous is happening. meeting in secret, and he puts up, or he firmly believes that, he is very sure, he firmly believes and put all logical reasons to convince you, but to you everything is illogical, but he put a lot because he firmly holds a belief. So that is what he expressed in this thought, that is the content of his thought. So delusion is a disorder of content of the thought. So delusion, these are firm, false, fixed beliefs held with deep conviction. They are illogical and they are not shared by others in his community, in his culture. So these are the features. So that is what he expressed. So these things are disorders of content of thought. So form, stream, possession, content. To summarize, derailment is a disorder of form of thought, then tangentiality, etc. is there. Then obsessions and thought alienation are disorders of possession of thought. Delusion is a disorder of content of thought. So this is what you should remember. And mental status examination components, terminologies are now frequently asked in entrance examination. So you should have an idea that when you study psychiatry nowadays, so you should have some idea about the mental status examination components, pathologies and terminologies. So these are important areas. So answer is A, derailment. Going on to the next question. A 16-year-old male patient presented with over familiarity. What does mean by over familiarity? Even when you don't know people, you speak as if like you are very much familiar to others, and shows even to strangers, they shows extreme familiarity as if like they are long lived friends or known for a long time, etc. Flight of ideas. You learned what is derailment in the previous. You can just remember like pressure of speech plus derailment is equal to flight of ideas. So derailment, you understand. What is pressure of speech? The rapid output of words. Some studies say quantity more than 150 words per minute, etc. Some say, just forget that, but anyway, rapid speech with derailment. This is classically seen in mania. Classically, that's what they say. That means it's also seen in hypomania, it can be also there, but or can be seen in other conditions, even psychosis, whatever it be, but classically described question is mania. So when to the question, the patient will be having a rapid output of speech with going from one topic to another without any connection. So flight of ideas plus derailment. Okay. Yeah, see, there was religiously was also there. So maybe it is like so Jack 340 was told religious. Maybe was it increased religiosity? Increased religiosity was that option? Maybe so. Just now I saw a comment in the video. So yeah, it can be seen. Then elevated mood, increased sexual desire, pseudo hallucinations. Okay. So what is all this? I will come to it. So first of all, this is a condition of a mood disorder. So mood disorder is a term which we commonly use. In DSM-5, how they classified this is, there is something called as bipolar disorder, there is a chapter, and depressive disorder. And there is something called as schizophrenia and related psychotic disorders. So, just to tell a story, first just tell a story. When DSM-5 was conceptualized, so when DSM-5 was conceptualized, first thing, they put a chapter called as psychotic schizophrenia and their disorders, and mood disorders. The bipolar disorder was put in middle was put in the middle of the topic, so as to act as a link between the psychosis and the mood disorder. Here there is a condition called as schizoaffective, because there is something called a schizoaffective disorder in the schizophrenia. This is psychotic, considered psychotic disorder, but that is also having symptoms of the mood disorder features. So here they put as bipolar 1 and bipolar 2, and depressive disorders, kind of major depressive disorder, etc. And cyclothymia is also included in the bipolar disorder spectrum. So, DSM-5, there is schizophrenia, and related disorders chapter. It contains schizoaffective disorder. So, schizomania or schizodepressive schizoaffective disorder, that comes with both schizophrenia symptoms and affective symptoms. So, that means it will have schizophrenia symptoms plus mood disorder symptoms. So, can be depression or mania features. So, both are there. So, to diagnose, you should have clear features of both schizophrenia and mood disorder. That considers psychotic spectrum disorders. So, now coming on to mood disorders. So, mood disorders, there is bipolar 1 and bipolar 2. So, if there is a manic episode or manic and depressive episode in the lifetime, then it is called as bipolar 1. So, to be in bipolar 1, the patient should be having one or more manic episode or mania and depressive episodes, then it is called as bipolar 1. If there is only hypomanic and depressive episodes, then it is called as bipolar 2. So, one confusion is, what is the duration in this question given? So, that is what can anyone tell anything else was mentioned about duration or anything about this question, because a confusion between the mania and the hypomania is coming up now. So, that is why, the duration I am just asking. So, okay. So, now comes a question, what is mean by mania, whether this, so we can rule out schizomania because there is no other psychotic symptoms. Pseudo hallucination is not a psychotic symptom per se. Now a question comes like whether it is mania or hypomania or cyclothymia. So what is the difference between mania versus hypomania versus cyclothymia? So now we need to understand what is the difference between mania, hypomania, cyclothymia. So first of all, I told you one thing, bipolar 1 should have one or more manic episode. I didn't say manic symptom, manic episode. And may or may not have depressive episode. See, this is very important because don't confuse episode with symptom. Don't confuse episode with symptom. For describing an episode means there should be a criteria. There should be a certain criteria should be met, not like one or two symptom. See, if you are having increased energy and increased speech, doesn't mean it is manic episode. That is only part of the symptoms. It should have certain set of symptoms. Okay. So bipolar 2 will have hypomanic episode and depressive episode. Okay. So now we are coming on to the important part. What is the difference between manic episode and hypomanic episode? So manic episode and hypomanic episode. For diagnosis, there is a typically, they say, a persistent, elevated or expansile or irritable mood plus 3 out of 7, or if it is only an irritable mood, 4 out of 7, if only irritable mood. See, the basic problem with mania and hypomania is that there is an elevated mood. You are full of energy. You cannot hold on to energy. The energy is full, and you somehow want to move it or pour it. That will reflect in your thought, it will your speech, your activity, everything. So this is the basic thing that is described for both hypomania and mania. And what are the features? There is a mnemonic. You can remember as dig fast. It is actually, even if you Google it out, you will see this mnemonic very common. It is something, a person called as William Falker of the Massachusetts University, who has given this quote. So what are the features of this dig fast? One is distractibility, that is, they get easily distractible. This goes from one thing to another, easily distractible. Second is indiscretion, that is, they will involve in activities without thinking about the consequence. For example, if I ask you to go to the top floor of a building and stand or look down or do something, you may sometimes be fearful because you know the consequence if you fall. But these people will do lot of things. They will race bike, etc. Lot of things they will do without thinking of the consequence. They are not afraid of the consequence. Next is grandiose ideas. These people will have grandiosity. You have a grandiosity or inflated self-esteem. I am something, I am great, I am reaching the top of the world, etc. This is there. Flight of ideas or racing of thoughts. Ideas goes fast without, from one thing to another without, and from one point to another it goes fast. Activity increased, psychomotor activity is increased. Sleep reduced and not needed. It is not decreased sleep, it is decreased need for sleep. They don't want sleep. Even without sleeping for less than 2 hours also, they are still very active and energetic. So that is called as decreased need for sleep. And next is talkativeness. Over talkativeness they have. Talkativeness over. The over talkativeness, they will talk without having connection from one point to another, etc. was there. So these are the features. These features are described for both mania and hypomania. So these are described for both mania and hypomania. So, but what is the difference? In hypomania, there is duration for more than 4 days, leading to a change in functioning of individuals. Plus, there is no psychotic symptoms. I mean, hallucinations or pseudo hallucinations. Pseudo hallucinations per se cannot be called, but they can also be included in this. Pseudo hallucinations can also be included in the psychotic spectrum. Like hallucinations, pseudo hallucinations per se cannot be totally a psychotic symptom. But anyway, for purpose practical sake, we can take into psychotic. Then, whereas in mania, symptoms should be either more than 1 week, or even if 1 day, severe enough for hospitalization or psychotic symptoms. So, once again I repeat, the criteria for mania and hypomania, symptom profiles that you can remember by the code DIGFAST, that is the same. But hypomania is the evolving phase, whereas mania is the advanced phase. That is what you can remember. For diagnosis of hypomania, these symptoms should be present for more than 1 week, and this should cause a change in the functioning, in the normal function of the individual, but it is not severe or disruptive like mania. Whereas mania, if present, it should be for either should be present for 1 week, more than 1 week, then you call it as it's fine, or it should be, even if it is 1 day, it is very severe to cause hospitalization, or there should be presence of psychotic symptoms like hallucinations or even pseudo hallucinations, lot of things. So this can, if that is there, then you should not call it as, or delusion of grandiosity, you should not call it as hypomania, it is mania. So it is that point, okay, which we can catch upon, which we, the better option can be mania than hypomania. If I agree that if you read the DSM-5 criteria, it is almost the same. The duration is not given. It is not even mentioned whether it is causing a severe dysfunction to the individual, but anyway, when all this reading together with the features and the pseudo hallucinations, everything, the psychotic symptoms together, I will go classically with mania than hypomania. I understand this is a difficult point to answer, but if an option is given, I will go for mania because of this. Features are same, but the presence of all this, the pseudo hallucinations, then classical description of flight of ideas, everything. So I will go for mania than hypomania. Though you may have some points to argue, sir, is it in the same in the DSM-5 criteria? The so-called psychotic or symptoms, all those things when it comes, I will go for mania. So, what about cyclothymia? But truly the question should have described about duration or the degree of disruption, or it should have more than pseudo hallucination. The better was if there was some delusion of grandiosity. If that was the options, then I would have without any doubt go for mania. What is cyclothymia? So, cyclothymia is also included in the bipolar spectrum. You can simply describe it like this, that is, for more than 2 years in adult or more than 1 year in children and adolescent, there should be continuous periods of hypomanic symptoms and depressive symptoms. It is not episode, it is symptom. When it comes to episodes, then it will goes to bipolar spectrum. So, bipolar disorder. Here it is, he may have for this 2 years, he will have periods of hypomanic symptoms or sometimes depressive symptoms. For this 2 years, it may goes ups and down. For some period, it may be hypomanic symptoms. After some time, it will be like depressive symptoms. And there is no more than 2 months of continuous stable mood. So, DSM-5 diagnosed like this, it should be for a period of 2 years. There should be periods of hypomanic symptoms, there should be periods of depressive symptoms, and there is not a period more than 2 months with stable mood. So, if you take this 2 years, only you can say maximum more than 2 months of a stable mood together. Otherwise, after which, beyond which, it won't be stable at all. So, not more than a 2-month period you can see in any time throughout the 2 years of stable mood. It keeps on varying between hypomanic symptoms and depressive symptoms. But hypomanic symptoms are not enough to qualify for hypomanic episode. Previously you see how you diagnose a hypomanic episode, the duration, etc. features. That much is not there, because maybe you are having 1 or 2 symptoms only, and for depressive also may have 1 or 2 symptoms, that is all. So, that is what is called as cyclothymia. So, this is what I have to tell about the second question, and the important area is a mood disorder. This is an important area of the mood disorder. So, you excluded schizophrenia, you excluded cyclothymia, and since the duration is not given, now comes the versus mania versus hypomania. The features with flights of ideas, elevated mood, increased and pseudo hallucinations, all this, we hope the examiner will be more expecting the classical description of mania. Now, coming on to the course of psychotherapy, psychoanalysis, psychology. So, this question, for that you should know a person called as Sigmund Freud, that is there in the psychology lectures, Sigmund Freud. The Sigmund Freud is an important person who has given various concepts like topographic theory of mind, structural theory of mind, etc. So, he is the propounder of one of the important concepts called as psychoanalysis. So, what is the basis? For that, you should understand that Sigmund Freud had a topographical theory of mind in which he told that there is something called as an unconscious mind, there is a preconscious barrier, and there is something called as a conscious mind. So according to him, all our experiences, all the childhood experiences, lot of all those experiences are all stored in this unconscious mind. It is a vast array of storage of all our experiences. Your childhood experiences, your emotions, your traumatic, lot of things are there in this unconscious mind. Now, lot of things, and that is your unconscious mind. It is outside your awareness. So, the unconscious mind, according to Sigmund Freud, it's outside our awareness. There is a conscious mind which we interact and is a conscious mind which deals with the external world, with the reality, with the external world, and is an awareness. Now, so what happens? All our experiences, like all those traumatic and painful or childhood, all experience what we have earned over these years, according to Sigmund Freud, is there in the unconscious mind. But sometimes, what happens if the painful experience come to your conscious awareness? All that are kept in the unconscious mind. There are some things which we have experienced in the childhood, lot of things which are in the conscious, which are within that, which are if brought to our awareness, it is painful. So, why does it not come into our awareness? That is what there is called as a preconscious repression barrier. There is a preconscious barrier between the unconscious and the conscious. There is a repression barrier. So, what is this barrier doing? It is like a barrier. This barrier breaks or prevents bringing up of all these things into the painful events into our awareness. So, there is something called as a preconscious barrier. But sometimes, so the unconscious, there is a preconscious repression barrier, and this is a conscious. Sometimes, but these experiences are all broken by prevented by the barrier, but sometimes it suddenly comes into the conscious awareness. When all can it come? It can come during dreams. So, what are the ways when this things in the unconscious mind breaks the repression barrier and comes to it? One is called as dreams. Dreams is called as a royal road to unconscious by Sigmund Freud. Then that is known as parapraxis, or what is called a slip of the tongue. Then what is called as abreaction, that is sudden emotional, it's like a sudden emotional ventilation of the painful experiences. So, during all these times, this can sometimes come from the unconscious to conscious awareness. So, based on this, he developed what is called as psychoanalysis. So, in psychoanalysis, there is a therapist, there is a subject. The subject is asked to lie on a couch. He is asked to speak of whatever it comes to his mind, whatever, without censoring. So, speak without censoring, without thinking or censoring. They are describing all those what has come to their mind, and the therapist will interpret based on this. That was the basis of psychoanalysis. Now, so these are terminologies: psychoanalysis, then what is called as unconscious mind, preconscious repression barrier, conscious mind, abreaction, then parapraxis, dreams, etc. So, during the part of this therapy, we know that relations or the therapist can develop certain feelings towards a doctor, or I mean to the patient. The patient can develop towards the patient, or client can also develop towards this. It can be sometimes something positive, it can be negative also. So, what the therapist develop towards the subject is called as countertransference. What the patient developed towards the therapist is called as transference. I remember like this: patient transferred doctor. When I was learning this, I used to remember like this: the patient didn't like the doctor and he transferred the doctor. So what the patient towards the doctor is called as transference, and the opposite is called as countertransference. And you should understand one thing: this can be positive or negative. It can be a positive transference, a positive transference, or it can be negative. This transference were important because that has got an influence towards the treatment also. But this is one thing. But mostly it will be, most part will be the unconscious. So the most important thing will be it's unconscious than conscious. It is mostly unconscious feelings. That's what to say. There is one another term called as rapport. That is a conscious interaction harmony between patient and therapist. That is with our knowledge and it's a conscious developing. Whereas transference and countertransference are mostly operating in the unconscious. That is what we say than conscious. But this is what you should remember because these are often asked in exam. So, I hope without confusion you should remember: the patient transferred doctor, the doctor counter transfer. The patient transferred doctor. So transfer means client to the therapist, and counter transference is therapist to client. So answer here it is B, counter transference. So I know that many times the exact wordings are not obtained, the question. So the thing is that the wordings has also got some, sometimes it may be confusion, but from what is available from this, this is countertransference. Now, this is another area, this is another important area often asked, and alcohol withdrawal. So usually the question shows a timeline. Say a patient stopped alcohol for 3 days and presented with irritability, disorientation, paranoid delusion, visual hallucination and altered sensorium. Likely diagnosis. So before going on to, so it's a withdrawal. So before going on to alcohol withdrawal, let us see. So here these points are important. Let us see what it is. So the first thing you should know about alcohol withdrawal is that why is withdrawal happening? See, the point you should remember is that the alcohol is a GABAergic agent. It's a depressant because it is a GABAergic agent. It is a depressant. That is why you have seen some people, when alcohol is not available, they will try to take benzodiazepine. And our treatment also for alcohol withdrawal mainly is benzodiazepine because both are GABAergic agents. So both are GABAergic agents. So when a patient on alcohol, when they stop alcohol, the GABAergic action is lost and it is counter opposed by the increased excitatory glutamate mediated effects. So what you should remember is that glutamate mediated excitatory effects are the mainly cause for the withdrawal. and it will lead to lot of symptoms. Now, what you should learn is this is something very, very, very important. So, what are the stages of withdrawal? The earliest sign to appear is tremor, which can appear in as early as 6 to 8 hours. So, then comes in 8 to 12 hours alcoholic hallucinosis. Alcoholic hallucinosis. In 12 to 24 hours or sometimes as early as 6 hours, there can be withdrawal seizures, which are generalized tonic-clonic seizures. And some say 36 to 72 hours, but usually they say 48 to 72 hours. One of the most important condition that can cause high mortality is delirium tremens. It is a serious condition. So, from this itself you got a point like what can be the likely answer, but anyway let us see. So, tremor 6 to 8 hours, alcoholic hallucinosis 8 to 12, withdrawal seizures 12 to 24 hours, and delirium tremens from 36 or 48 to 72 hours. Usually 48 hours, 3 days after last drink is a typical question. So, tremor is the earliest classical and the most common sign. Tremor, most common. Coarse tremor, postural, that is when you do the posture, it comes a tremor, that is postural tremor. Symmetrical, both sides it's together. 8 to 12 hertz, low amplitude. And there can be other symptoms like anxiety, nausea, sweating, headache, etc. So, lot of not only tremor, sometimes other symptoms may be much severe. So, lot of autonomic symptoms can be there. One of them will be tremor. So, the most classical symptom is tremor. And alcoholic hallucinosis, sorry, this is 8 to 12 hours. I have mentioned here it is like 8 to 12 hours. So, alcoholic hallucinosis means the subject will start hearing voices, like somebody abusing him, shouting at him, loud sounds causing fear, etc. But the subject will be in clear sensorium. So, differentiating feature of hallucinosis from delirium is that in hallucinosis, the subject has clear sensorium. If I am having hallucinations, I know that I am taking class for you, I am talking here, what I am talking, everything I am clear, but I am hearing sounds, loud sounds, sometimes some shouting at me, sounds of some animals or frightening sounds, etc. I will look around and see, but I don't see anyone, but I can clearly hear the sounds in the ears, then that causes me intense panic. But I am oriented to my time, place, person, I know what I am doing, but I cannot control the sounds I am hearing. This sort of phenomenon is happening. That is called as alcoholic hallucinosis. It occurs in 8 to 12 hours. Now, there is something called as withdrawal seizures, 12 to 24 hours. Sometimes as early as 6 hours. The usual timeline they say is 12 to 24 hours. And it will be generalized tonic-clonic seizure. If it is focal seizure, it is require further evaluation because it is unlikely due to alcohol. and they can have, after a first seizure, in 3 to 6 hours they will have another seizure, then after 3 to 6 hours another seizure. This is called as cluster seizure. They can have a cluster of seizures. So that is what you should know about withdrawal seizure. It is a GTCS type of seizure. There can be cluster seizure 12 to 24 hours, and it can occur as early as 6 hours. Focal seizures means you should look for something else too. And now comes to delirium tremens. So this is one of the most important thing you should know about exams, also in practical life, because this is a condition you should anticipate. They can cause high mortality in this individual and needs urgent interventions. So usually what occurs is that it occurs typically as per the question given. It occurs in a time span like 48 to 72 hours or 36 to 72 hours, some they say. 2 to 3 days, usually they say is 3 days after, so maybe 36 to 72 they say, but mostly 48 to 72, 36 to 72. So at least after 2 days you can remember, 2 days or 1.5, 2 days for minimum. Here what happened, there is delirium is the key feature. They may start with some insomnia, tremulousness, fear, but thereafter the clouding of consciousness and confusion. There will be altered sensorium. The subject will get like in a confusion. He is not able to orient himself or sustain his attention. He is distracted. His orientation to time, place and person. He is not able to correctly tell a time, sometimes correctly identify the people who are around, or correctly locate a place where his sensorium is confused and clouded. There can be vivid hallucinations, mainly can be visual, auditory, etc. They can have delusions, paranoid ideas, fleeting delusions that somebody is trying to harm, etc. People around are trying to do something. Then they may have visual hallucinations, illusions, etc. Tremor, and there will be autonomic hyperactivity. So these are important features that can happen. So these are the features you should remember. There will be autonomic hyperactivity, delusions, hallucinations, illusions, etc. Psychotic symptoms, disorientation, altered sensorium, clouding of sensorium, and the timeline will be, the timeline mentioned will be, this is the timeline mentioned. Now Wernicke's encephalopathy and Corsac of psychosis. So the basic thing you should remember is the thiamine depletion. Alcoholics are short of nutrition and thiamine depletion can happen. Wernicke's encephalopathy is like a presence an acute condition, whereas the Korsakoff is like a chronic conditions. GOA, that is global confusion plus ophthalmoplegia plus ataxia is the major features, whereas Korsakoff andrograde amnesia, that is new learning is affected, and plus recent memory impairment. There is a query like treatment of delirium tremens, Tariq. Yes, I will come to it, Tariq. I will come to it. So andrograde amnesia plus recent memory impairment. I will just come to it again. So since we are discussing about, I will come to it, the treatment also, delirium tremens, I will come to it, but just so Wernicke's encephalopathy. It's an acute condition. There is depletion of thiamine. it causes neuropathological injuries in the mammillary body plus thalamus, cerebellum, etc. will be affected. GOVA, that is global confusion plus ophthalmoplegia, that is the sixth, mainly the lateral actor sixth nerve palsy plus ataxia. It's an emergency condition. The earliest to resolve with treatment, you give high dose thiamine. The earliest to resolve is the ophthalmoplegia, and what can remain is ataxia can persist. Residual ataxia can be present. Treatment is thiamine, high dose thiamine, that is you give thiamine supplementation 200 to 250 mg. Thiamine supplementation first 5 days, for 5 days you give thiamine supplementation. Whereas this Korsakoff is a chronic condition. Here the medial, the mammillary body plus medial thalamic nucleus plus hippocampus is also involved. So, what happens if hippocampus is involved? Memory. So, memory is affected. So, memory, mainly what happens is that there is anterograde amnesia, that is the new learning is affected, that is after the insult, the new learning, thereafter the things that learned after this new learning is impaired. Recent memory is affected, whereas a remote memory is relatively spared. Relatively spared remote. And retrograde amnesia can also occur, but less severe, that is amnesia to events before the insult. So, mainly after the insult the new learning is affected, anterograde memory is mainly affected. The retrograde memory, that is before the insult, that can also be sometimes affected, but less severe, and recent memory is mainly the affected thing, and remote memory is relatively spared, and there can be confabulation. See, what is confabulation? Confabulation may be seen, not always seen, it may be seen. May be seen means like it is like a fluent lying. The patient will have memory gaps, but they will fill it with stories, as if not as if they remember, and they will fill it with stories. It is not like they purposely understand that I forget that, okay, I will just add. It is not like lying. When we purposely lie, we know that it was not there and we add on to it. But here, without knowing that, thinking that it was there, they keep adding. That is why it called as fluent lying or confabulation. It is not a mandatory feature, it can be present. Because of this memory gaps they have, they will keep this. So, since Tariq, I also added about treatment of delirium tremens. So, when you get an alcohol withdrawal, case, say it is in delirium tremens, as so you ask for treatment of delirium tremens. First thing I will do emergency investigations, because it can have lot of electrolyte imbalances, etc. High dose thiamine I will be giving, because assuming that there will be short of thiamine and nutrition. So, I will give the injection polybion optineuron is there, which we give in 5 ampules in 100 ml in 100 ml NS, rather than DNS or rather than D5 or dextrose. I will prefer NS or something, because that is ideal. RL or NS is ideal fluid. And benzodiazepines are the drug of choice. I told you, because either you have to give alcohol or give something that's similar to alcohol. Here GABAergic agent benzodiazepines are given. So, there are various regimens like symptom triggered regimen, fixed dose regimen. I am not going to, so I may be some days giving injection, and even when I taking benzodiazepine, I will prefer lorazepam if the hepatic status is not known, oxazepam or lorazepam, but mainly what we have is lorazepam here. So, I will prefer lorazepam if I am not aware of the hepatic status, because diazepam, chlordiazepoxide are benzodiazepines which we can give, but if hepatic status is unknown, we will go with lorazepam. So, I will give something like 4 mg, 2 mg, 2 mg, 4 mg like a dose. You can give 12 to 16 mg usually, even the maximum dose we usually give 12 to 16 mg, rarely we go beyond, but anyway we give this, and every 2 days. And I always daily will put a charting called a SIVA score. There is a Clinical Institute of Withdrawal Alcohol, based on the symptom severity we assess by a score, and every 2 days we taper the benzodiazepines and ultimately taper and ultimately maybe by another 10 to 12 days he is out of this. That is called as detoxification. So, though delirium is high mortality, but because of proper care with all support system, he will improve, like this patient will improve. And hydration, electrolyte balance, all other metabolic parameters, everything should be taken care of. And after this detoxification, once out of this, we will look for long-term management aspects. And these things are something which we have already discussed in our alcohol-related topics in our class. So, these are the points which I want to discuss with you. So, the thing I need to tell you is, like, exams will be again coming up. You should learn psychiatry under the settings: psychopathology terminologies, clinical scenarios, how to diagnose based on a clinical scenario, and third one is psychopharmacology. I am surprised that no questions have come from psychopharmacology, but this is also very important because lot of questions can be asked from this. So, minimum at least these three things should be, you have an idea when you should learn psychiatry. So, the paper was relatively easy paper this time compared to last time. Comparatively common questions were mainly asked. So, I hope you will take care of these 3 points, particularly when it comes to the next discussion. So, thank you for this patient listening.